First of all, it's interesting. Let me tell you my experience with guidelines, because I'm the editor of the guidelines of the German Society of Neurology, and I have to edit 130 guidelines. These recommendations are based on properly conducted randomized trials with predefined endpoints. And if we look at the scientific evidence for this procedure, the two trials were negative. You can turn it around as you want, and you can look at it from different angles. These were negative trials. So if I go to neurology meetings, stroke meetings, someone gives a talk on prevention of atrial fibrillation and mentions LLA occlusions, they will say, this doesn't work, we have two randomized trials, they are negative, forget it. Now if I go to cardiology meetings, it's the other way around. Everyone says we have two negative trials, but it works. It's the same with PFO, by the way. In all neurology meetings, they say, don't touch the PFO. And in all the cardiology meetings, he says, whenever you see a PFO, close it. So there's obviously a disconnect. And I heard the disconnect today very clearly, the message. The patients that you treat are very different from the patients who were put into the randomized trials. So we cannot translate what we saw in the randomized trials into your experience. Now, the second best thing to do after a randomized trial is a proper registry. But a proper registry means not only it's prospectively collected data, you need a predefined comparator group. What you never should do, I always saw this on the slides, it says this is a calculated stroke risk from the CHEST-VAS score. No way you could do this because these are always biased data. The only thing you could do is what's called propensity matching. So you have one population with an intervention, you have a control population without the intervention, then you match individuals for the same risk and you look at long-term follow-up. This is by what the FDA did for the long-term data with the Bigatron, 134,000 patients, but then 75,000 could be matched exactly for risk, and then you can do something. So if you do registries, do them in the correct way. And I have a 25-year history of doing registries. And I made all the mistakes in the world you can do in registries, so I'm very experienced. I just can tell you this has to be done in a very proper way. Now, if I have to put up my wish list, what I would like from you is a priority list. Which patient is in highest need of this procedure? Is it a patient who had a stroke and has a high bleeding risk? Is this a patient on dialysis? Is this a patient who cannot take warfarin for whatever reason or cannot take a novel anticoagulant? And I think once this priority list exists where you say, this is priority number 1, number 2, number 3, the company has to go back, the companies have to go back to the drawing board and said, is it worthwhile to do a randomized trial in this group of patients? Yes, it is. Why? We cannot afford to have controls which are not anticoagulated long-term because they have this high risk. And it's ethical, I think, to randomize these kind of patients. But my understanding is these trials have to be done. It's not enough to have registries. Now, you heard in the final part there is a very important issue, and this is reimbursement. We not only have to convince our colleagues, nephrologists, internists, cardiologists, and neurologists that this is worthwhile. Much more important it is about reimbursement. And the United Kingdom has a NICE, we have another institution, and they also look now at procedures. And they will no longer reimburse procedures if there is no evidence, number 1, of efficacy, and number 2, that is cost effective. And they now start to look at devices and they evaluate devices. I give you one example. We used to use stents for intracranial stenosis, symptomatic patients. There was a randomized trial. The trial was negative. Our reimbursement people 6 months later said, this is no longer reimbursed because there is a negative study. And this could happen to this procedure, at least in my country. And you have to provide proper data. And the best data you can provide is from randomized trials. Sometimes the authorities will accept registry data if you can convince them that there is an ethical problem with a control group in terms of how this control group is treated. But the best thing you can do is a proper randomized trial. And I would like to give you another example from thrombectomy. Thrombectomy in acute ischemic stroke, these are people who have an occlusion of the internal cardiac artery or the middle cerebral artery. There were 3 trials published 2 years ago, and they were all negative. Now, the reimbursement people came to us and said, we give you 2 years. We are aware that the devices that were used were not very good. And now you have made progress in the devices that you use. You also made progress in the devices. And now it's time to do a second round of randomized trials. And these were done, and they were made public a week ago. It's 4 trials which are now positive. And now the reimbursement people are saying it's no problem, we will reimburse it. Because number 1, we have scientific evidence, numbers needed to treat is 3, and this is definitely cost effective. This will be reimbursed all over Germany. I think that's the way we have to think for the patients, for the science, and for the reimbursement. So that's thoughts from a neurologist. And since neurologists are notoriously compulsive and obsessive, they always want to finish on time. And this leaves me for a big thank you. Number 1, for the company for inviting us. Number 2, my personal thanks, because I have to admit I learned a lot. Despite the many abbreviations you use, sometimes I got an idea what the issue is. And I would in particular like to thank the speakers, because they all kept times. They gave very good lectures. I think we all learned a lot, and I have to thank my co-chairman, Professor Lewalter, for joining me in this meeting. So thank you very much, all of you, and you have please fill in the evaluation sheets. Thank you.
Super. Wunderbar. Eine runde Sache.